we, so robotics or the surgical robotics is a machine which allows surgeon to perform many complex procedures with introduction of a computer interface and the integration of mechanical arms between the surgeon and the patient. So in this picture, we can see the Frederick Moll, who is known as the father of robotic surgery because of his invention and his works, which helped to pave the way for improving the surgical procedures for the decades. Sir, Navneet sir.
Yes.
Hello. Sir, my slide is not moving, sir.
Click once on the presentation. Just click once on the presentation. It will move.
Yes, that's right. So if we see the different Da Vinci models, the first one is the Da Vinci Standard, which came out in 1998, followed by the Da Vinci HD, which came out in 2016, followed by in 2019 Da Vinci SI, then Da Vinci XI in 2014, and Da Vinci X in 2017. So other than Da Vinci, there are three other renowned robotic models, which are Senhance Surgical Robotic System, which got USA approval in 2000, USA FDA approval in 2017, and that is the Medtronic Hugo RS system. Then in India made is the SSI Mantra. If we see the difference between the Da Vinci system and the these three, so here we can see the patient card arms are single, and so the docking will be easy and quick. So Hugo RAS system is has not received the FDA approval, but it has received the approval of the European Union by 2020. And SSI Mantra has received the Indian Medical Device Regulatory approval, but FDA and CE mark is yet to be received. Now, if we look at the cost, the SSI Mantra cost around 5 crore, while the Da Vinci surgical robot price cost around 15 crores. So, what are the challenges do we face in the laparoscopic surgery? So, we can see at the entry point of the trocar in contact with with the skin and the abdominal wall, there is a fulcrum effect. So, there will be counterintuitive movements, and there will be though if it is not a 3D laparoscopy, usually the lack of depth, the lack in the depth of perception is there. Then difficulty in the hand-eye coordination, dependency on the assistant for camera and other procedures. And then if we look at the learning curve, it is a steep learning curve. Now, if we compare between the laparotomy, laparoscopy, and robotics, if we look at the advantages in the laparotomy, so here we can have the dexterity, that is the skillful hand movements, flexibility, it is affordable, and it is ubiquitous available. And the disadvantages, if we see, it is prone to have the human tremor and fatigue, limited to the geometric accuracy and a longer post-operative course. In case of conventional laparoscopy, so it is a well affordable, developed, affordable, and ubiquitously available, and it broke the ADTC. So though there is not complete loss, but there is some little bit of loss of haptic perception. Then loss of 3D visualization. If it is not a 3D laparoscopy, then limited degree of motion and dexterity. And there is in laparoscopy, there is an amplification of the physiological tremor. But in case of robotic assisted surgery, the advantages are 3D visualization, increased degree of motion, improved dexterity over the laparoscopy, then elimination of the tremor, good geometric accuracy, then it is profitable for the surgeon because surgeon will be sitting all the time. The disadvantages is absence of the touch sensation. It is expensive new technology and requires additional training. And if we look at the trocar size, in case of laparoscopy, the trocar size of the smallest size is 5 mm, but in case of the robotics, it is 8 mm. So there is a study. The title is Patient Benefit While the Surgeon Suffers. So 87% cases that the laparoscopic surgeon will have some kind of body ache like neck, head, and lower extremity pain. Now, in case of robotic, the 7-degree motions are the advantageous point. Number one is we can see what are the movement. One is rotation, in and out, pitch, that is the side-to-side axis movement, then yaw, which is vertical axis movement, then there will be wristed wow, wristed pitch, and the grasp. So in the robotic system, what are the different components? The three main components are the patient side card, then the computer stand or interface, and the surgeon console. So in the patient sidecar, which is a mobile unit positioned beside the patient and support the central overhead boom with four arms. So which are numerizing 1, 2, 3, and 4. Usually the number 2 is kept for the camera. So whenever we are seeing the surgeon is moving the doing the movement, and it is executed on the patient, and again from the patient it is shown in the monitor. But is it a real-time execution? The answer is no. So if there is some movement occurs within 300 milliseconds, the human eye cannot differentiate it between a different movement. So it will look like a real movement. So if we look at the master controller to the patient side robotic arm transmission, it requires 20 milliseconds. And from the endoscope to the 3D monitor, it requires 80 milliseconds. So we know for ship or the boats, there are two kinds of docking. One is dry docking, that is on the land, and another is the wet docking. So similarly, we do robot docking. So docking is a process of placing or assembling one platform with other to predict the preferred orientation from the stable model. So the steps of docking are number step one is the deploy for docking, that is unlock the patient card. Step 2 is the drive the robot to the bedside, and the step 3 is the Da Vinci targeting, that is by the laser ray, and also we can do manually as we do it in case of laparoscope. And the step 4 is the attachment of all the board brokers. So the step 5 is the optimization of the arm position. Step 6 is the insertion of the instruments. So here this is the motor drive. So at first we have to press the power button, and here we can see the throttle enable switch. So you have to squeeze it to move it and to drag it towards the patient. Similarly, in the SSI mantra robot, we can see there is a touchpad, and there is also the buttons. Like at first we have to press the unlock button, then we can change we can drag the patient card, and there is also a separate button to raise or to pull down the boom below. So for pelvic surgery, docking can be done in a two way. That is the side docking, which is from the lateral part of the leg, and central docking, which is in between the patient leg. And for upper abdomen, we can do that is the side docking and the central docking. Side docking is from behind the shoulder, and central docking is from behind the head. So the fourth position here we can see in the SI or the Da Vinci SI model, it is like the diamond baseball concept what we do in case of laparoscopy. But in case of XI model, here all the fourth position would be in a linear straight line. Here we can see the surgeon console, and here it is the stereo view. So in the stereo view, we will get to see the 3D vision. And whenever the surgeon head is out of the stereo view, it has a sensor, so everything will get fixed. But in case of, but it has been seen that because of the use of stereo view, the robotic surgeon don't suffer from the neck pain. But in case of Kuboras and SSI mantra, we can see it is an open console, so there is no such complication. So here we can see the foot switch panel in case of Da Vinci. So the number A is the toggle pedals. Toggle pedal, by pressing the toggle pedal, we can switch the arm. Like the surgeon wants to shift the arm 1 into an arm 3 and the arm 3 into arm 1. So the surgeon needs to press the toggle pedal. So and above that there is a for C we can see the foot clutch. By pressing the clutch, we can adjust the distance of the master controller. We can make it near or make it far. And this side we can see the two yellow pedal. This is for cutting right side and left side. And below there is a coagulation pedal, which is colored as a blue. So coagulation pedal, and this is the number B is the camera pedal. By pressing the camera pedal, we can change the field of vision. Now the ergonomic control on the left side, there is an ergonomic control, so we can move up and down and right and left of the master controller. On the left side, we see the power control port in which there will be different buttons like power button. If there is any inadvertent injury, then we have to press the emergency stop button. So this is a master controller, left and the right hand controller. Here we can see. So while doing twisting, the control handles, it causes tip of the instrument to rotate, and while doing squeezing, it controls the hand and resulting in the opening and closing of the instrument. Here we should note that the surgeon movement of 3 mm on the hand control, it translated to 1 mm instrument movement inside the patient body. So in case of Hugoras and SSI mantra, there is no finger ring. It's like a two button we have to squeeze. So in here we can see this is the in the armrest. That is, there will be central touchpad. In the touchpad, we can log in and we can register the patient data, and we can change the different mode of the coagulation and cutting. So near the stereo here, there will be a mic and the audio speaker. So whatever the surgeon wants to convey to the to his assistant or the OT staff, it will be transmitted to the vision card. There will be another speaker open, and all the person in the OT will be able to listen to the surgeon's direction. So the here the vision card contains the that is the one is the monitor with illustration, then electrosurgical unit, then endoscope controller, and the imaging processors. So as a surgeon console, there will be one teaching consoles are also available, so the students can sit and they can learn and see the surgery. So in the HD Studio camera, it is a binocular camera just like a human eye. It gives a nice 3D vision. And tourist instrument, while purchasing, we will get the two kind of tourist instrument like blue or red. Red instruments are for demonstration purpose is animal. It can be used for 30 times. But in the blue color instruments, instruments is used only for 10 times. So the most commonly used instruments are curved monopolar scissor, then hook monopolar cautery, Mendelian bipolar forceps, fenestrated bipolar forceps, suture cut needle driver, and the progress bar. In this picture, we can see the different types of trocar. Number A, we can see the Da Vinci XI trocar, and the picture B, we can see the Da Vinci SI 12 mm camera and other accessory trocars. And number C, we can see all the 8 mm trocars. In Da Vinci XI model, it provides the newer model provides the accurate suction irrigation and the vessel sealer. Now, so the newer Da Vinci SP, which is coming up, it will contain the single side port for which the different instrument and camera will come out. Now here the positioning of the patient, the commonly used position in case of gynecological surgery is the Lloyd Davis position, and here the Allen stirrups are used to guard the calf muscles and prevent the peripheral neuropathy. So the different trocar configuration in XI model, as I told, it will be all linear. Here A and A plus is the accessory trocar point, and the point 2 is the camera point. But if it is not an XI, then we have to follow the diamond, the baseball model, where here we can see the distance between the trocars are maintained, that is 8 to 9 centimeter distance is maintained. So in case of simple hysterectomy, robotic hysterectomy, either 4-port or 5-port can be inserted. 4-port with two instrumental arms and the other assistant port, and or 5-port with the 2 instrument arm and the bedside assist port. So while placing the trocar, there will be 3 marks, 2 thin black marks, and in between the 2 thin marks there is a broad, large, thick black mark. So while inserting the trocar in the abdominal wall, so it should be in between the thick black mark, so that we can decrease the torque on the abdominal wall. So in this picture, we can see the port placement and docking. in a remote place, so he does not require the whole console. He will use this portable mixed reality console, and he can guide the operating surgeon. This is the correct thing, or here you should do incision, or here you should cut, or like that. So it's a very useful device. Now, if you look at the Indian experience of the robotics in gynecology, so the study was conducted by Shailesh P. Puntabagar in the Galaxy Care Laparoscopy Institute, and the paper was published in 2014. So here we can see that a total 80 cases, out of them 29 were benign and 51 were malignant cases. So this was the largest series at that time, and benign and malignant cases were addressed robotically, showing the feasibility in India. Now, the robotic surgery for ovarian cancer. So, robotic approach can be safely used in the well-selected patient with early-stage ovarian cancer. However, the minimally invasive surgery in the patient with advanced stage or the relapsed ovarian cancer requires further investigation, even in selected cases. The role of robotic surgery in ovarian cancer is still ill-defined. Although the robotic is feasible, but has not shown in extra benefit of overall survival. In other than primary tumor removal and staging, if it requires two additional procedure, then it is best to do open surgery. Here we can see there are different old studies like the Magrina et al., Nesat et al., Brown and Chen et al. These studies have shown that in early stage ovarian cancer ovary, robotic surgery is feasible. Now, the study conducted in the 2019 and published in the HOC journal, this is a Faisal Benjin et al. The study contains 1901 patients who received minimally invasive surgery. There were two arms, robotic versus traditional laparoscopy arm. So the conversion rate in case of robotic was 7.2% versus 17.9% in case of laparoscopy, which is significantly lower in case of robotic surgery. In multivariate analysis, there are no significant differences in the survival between the two arms. Now, there is a meta-analysis conducted by Shai Ji et al. 8 studies were included, and the total number of patients were 647. So there were two arms, 3 arms. That is a robotic versus laparoscopy is one arm. Another arm is a robotic versus open. In this meta-analysis, the robotic surgery and laparoscopy presented the same effect in the treatment of ovarian cancer, while the robotic surgery provides lesser estimated blood loss, low length of hospital stay, and less postoperative complication, and higher overall survival rate versus laparoscopy. Similarly, there is another meta-analysis by Tang Q et al., which is published in 2022 in the Journal of Oncology. 38 studies were included, and the comparison group was laparotomy versus robotic and the laparoscopy. So the results were compared with laparotomy, robotic, and laparoscopy had a shorter hospital stay and decreased blood loss, fewer complication, and the 5-year ovarian cancer patient has no difference in the robotic, laparoscopy, and laparotomy groups. So the new ongoing study, which is mirror study, that is minimally invasive robotic surgery, role in optimal debulking ovarian cancer recovery and survival. So this study is going on in UK. The study is open in June 2020. The eligibility criteria is an adult woman having the advanced ovarian cancer or fallopian tube cancer stage 3C to 4B, and the patient will be receiving the neoadjuvant chemotherapy and plan for the internal debulking surgery. And the pelvic mass should be equal or less than 8 centimeter. And there should not be any other reason to requiring open surgery, such as extensive disease or upper gastrointestinal resection. Now, why it was the studies has been conducted, the cause is that in UK it has been shown that in England 60.1% of the women over the age of 79 years diagnosed with ovarian cancer. To deal with such an older and a frail patient, it is not always possible to do the extensive surgery. So the ability of them to provide the same surgery via a minimal invasive route, such as robotic surgery, potentially widens the access the treatment to the cancer patient. So the what is the aim? Number one is that to improve the patient experience. Number two, to access the surgery for such frail and old patient. Number two is early recovery, reduce the morbidity. and reduce the time of chemotherapy by incorporating the robotic surgery on those ovarian cancer patients with a pelvic mass less than equal to 8 centimeters. Now, the robotic surgery in the uterine cancer. So there are two randomized control trial in the that is laparoscopic trial. If we see the LAB2 trial and the LACE trial, and the LACE trial, and LAB2 trial, the stage 1 to stage 2A endometrial cancer were randomly allocated into 2:1 patient to laparoscopy versus laparotomy. If we look at the conversion rate, it was 35.8% in case of laparoscopy, and the recurrence rate was 11.4% in laparoscopy versus 10.2% in case of laparotomy. And 5 years overall survival was almost identical. So the conclusion of the LAB2 trial is a laparoscopic approach is a feasible and a safe when compared to laboratory and superior with the for the short-term safety and length of the stay endpoints. In case of LACE trial, we can see that is the 353 patients was there in a PHR, that is abdominal approach, and 407 patients in the laparoscopic approach. And the stage 1 endometrial cancer, the total abdominal hysterectomy compared with total laparoscopic hysterectomy resulted in equivalent disease-free survival at 4.5 years and no difference in the overall survival. So the conclusion was the use of laparoscopic hysterectomy for women with stage 1 endometrial cancer was feasible, and it can be taken as the standard of care. Now, coming back to the laparoscopy robotic surgery, here we can see the Manepa MM et al. In 2016 published one randomized controlled trial in which 101 endometrial cancer patients were included, and there were two arms: robotic surgery 50 patients and laparoscopic surgery 51 patients. So in this study, the patient with endometrial cancer, robotic surgery was faster, that is median time was 139 minutes. Then the traditional laparoscopy median time was 170 minutes, which is significantly less in case of robotic surgery. If we count the docking time also, the robotic surgery group, it was the total time was 197 minutes versus in case of laparoscopy it was 228 minutes. Again, it was significantly less in case of robotic surgery. In the laparoscopic arm, there was 5 conversion to laparotomy, but no conversion in case of robotic arm. So the conclusion is robotic surgery offers an effective and safe alternative in the surgical treatment of endometrial cancer. Another systematic review meta-analysis which contains 21 articles and it is done by PUH et al. There are 3 comparison group: robotic versus laparoscopy and laparotomy. And this study has shown that robotic surgery is safe in the management of the endometrial cancer with long-term oncological outcome equivalent to the traditional laparoscopic surgery and superior to the laparotomy. Now, another randomized controlled trial in case of high-risk cancer endometrium of stage 1 and 2. So the primary outcome was periodic lymph node count. So there are 2 arms, robot versus laparotomy arm. The mean periodic lymph node count was 20.9 in case of robotic arm and 22 in case of laparotomy. The mean pelvic node count was lower in case of robotic arm, but there was no difference in the perioperative complication or readmission rate. The operation time was longer, but blood loss was less in case of robotic surgery, and hospital stay was low in case of robotic surgery. And if we look at the cost from the admission to the discharge, the mean difference is it was less in case of robotic than the open because of shorter hospital stay. Now the conclusion is non-inferiority in the periodic lymph node count, comparable complication rate, and shorter hospital length, and lower total cost of robotic surgery over the laboratory. Now, regarding the obese patient, we know the morbidly obese patient, the BMI is more than 50 kg per meter square. But in case of super morbidity obese patient, the BMI is more than 50 kg per meter square. So, total patient 168 patients were included, and this study shows that in out of the 168 patients, 30 patients had super morbidity, that is BMI more than 50 kg per meter square. This study has shown that in super morbid obese patient also robotic surgery is safe and feasible. Now the robotic sentinel lymph node detection, that is a Firefly Da Vinci robotic system is used, and the near infrared imaging is used for the detection of the ICC type. So there are study by Bizari and et al. It's a retrospective study which contains 549 patients and 52% patient in case of laparoscopy and 47.9% in case of robotic. The conclusion was sentinel lymph node mapping and bilateral sentinel lymph node detection with ICG in endometrial cancer was not different than the laparoscopic arm. Now, there is a study, Indian study conducted in the TMC Kolkata by Roy et al. It's a single center prospective observational study. And in this study, the 105 female patients were included. And in this study, we can see the sensitivity of the sentinel lymph node in the ICG algorithm was 92.3%. Negative predictive value was 98.3%, and alpha staging necessitating the staging in 8.57%. So we can draw the conclusion from this study that with a very high negative predictive value, sentinel lymph node mapping with ICG type has a high degree of diagnostic accuracy in detecting the sentinel lymph node mets in case of endometrial cancer. Now, the robotic surgery in the vulvar cancer, there is a video endoscopic inguinal lymphadenectomy veil surgery, which is also known as a veil surgery, that is robotic assisted inguinal lymphadenectomy. So here, if we look at in the exercise system, there will be with single docking we can do just moving the patient card. But in case of SI movement, 45-degree movement is required from right to left side. So in this picture, we can see the veil surgery, and here we can see the seminofemoral junction and the adductor longus and the sartorius and femoral artery. So there is another Indian study conducted by Rupender Shagan and Vandana Jain at Rajiv Gandhi Cancer Hospital. It is a retrospective study conducted in the 12 patients. In this study, the mean operative time was 69.3 minutes. Mean blood loss was 30 ml. No intraoperative complication was observed. Drain was removed at a mean time of 13.9 days. And the lymphocyte was in the 6 groins and chronic lower limb edema seen in case of 6 cases. Prolonged lympharia in one patient, that is one side, and cellulitis in the 2 groins. So overall, the RVL allows the removal of the inguinal nodes within the same limit as the open procedure for inguinal lymph node detection, has a potential to reduce the surgical morbidity associated with open procedure. Now, robotics in the cervical cancer. So we know the LACC trial. In the LACC trial, the stage 1A with LPSI positive, stage 1A2, and stage 1B1, that is the FIGO 2009 older classification up to 4 cm cervical cancer with a histological subtype of squamous cell carcinoma, adenocarcinoma, and adenosquamous carcinoma has been included. So total 319 patients, and the patient in the minimally invasive arm and 312 patients in the open arm. In the MIS arm, 84.4% had laparoscopy, 15.6% had robotic assisted surgery. And if we look at the disease-free survival, disease-free survival was low in case of MIS arm, that is 91.2% versus 97.1% in case of open arm at 3 years. And it also shows that the lower rate of overall survival, that is 93.8% in MIS arm versus 99% in case of open arm. Now, the critical appraisal of the LACC trial, the surgeon proficiency criteria for MIS radical hysterectomy in that trial was that is the submission of the 10 MIS cases and 2 unedited operative videos. So radical hysterectomy, we know it's a complex surgery, and it means extremely a skill, and it also requires the steep learning curve. In this study, the average percentile case distribution was as low as 10. So the 10 patient per arm was recruited over 9 years, which is very low. We don't know whether all the participant surgeons had an opportunity to maintain the adequate proficiency during the decade of accrual. Another is the LACC is an internationally collaborative multi-centric study conducted in the 33 centers in the reputed across the global centers. And the reason for conversion, it has been shown that for 10 patients it was done, but the reason was placed like a poor visualization equipment failure at the prolonged operating time, which is very difficult to accept. The routine use of uterine manipulator causes tumor fragmentation, and this which is against the norm of oncosurgery, but it has been done in almost all the patients. So the accepted oncological norms not directly handling any tumor was not used here. The missing the histopathological data in almost a third of the cases and inadequate follow-up data also add to the lacunae. The author concluded that their result cannot be generalized with low risk patient for the tumor size less than 2 cm, no LBSI, depth invasion less than 10 mm, and the no lymph node involvement, as the trial was not powered to evaluate the oncological outcome in this group. So, but if we look at the result, the lower risk criteria was 48 to 87% in the study. 52% of the patient in the trial had the tumor size of 2 centimeters. 67% had no LBSI. 48% had the that is a superficial to middle depth of invasion. 86% were node negative. So the data published and their own statements appears contradictory to each other. Regarding the intercorporeal pulpotomy done under the carbon dioxide gas causing pneumoperitoneum is often incriminated in the causing the tumor dissemination and the port recurrence. It should be noted here that after pulpotomy, the gas escapes out from the vagina, thus blowing away any small tumors. So there is a meta-analysis by Mox et al. Of the 20 randomized control trial performed on the animal showed that carbon dioxide pneumoperitoneum does not enhance the own metastasis and following the laparoscopic abdominal tumor surgery. So what is the impact of the LACC trial? If we look at the different organization like Society of Gynecological Surgery, AGA, AGO, now they suggested to do the counseling with the patient and to inform the patient that there is a lab trial and these are the treatment options are available. Now the robotic organization like Asian Society of Gynecological Robotic Surgery, they advise to counsel the patient about the LACC trial and all the available treatment option, let the patient to choose. But the Society of European Gynecological Robotic Surgery, that is SERG, gynecology, so they also advise for counseling, and but the society does not currently recommend change from the MIS to open surgery. Now, what is the need of the hour? Other than this LACC trial, if we look at the Swedish quality register, there were 822 cases of the radical hysterectomy which is followed, which has been done from 2011 to 2017, and these are followed up, and it has been shown that from the audit that there is no difference in the survival or overall survival, and similar result has been obtained from the Danish quality register. Same result has been reflected in case of Nordic county register also. So in the Nordic county register, healthcare system have gradually adopted a robot-assisted laparoscopic surgery, and its perceived safety is supported by the data from their register. So, however, the LACC trial is currently the only randomized control trial exploring the oncological safety of the minimally invasive surgery. And to establish the safety of current practice, a new randomized control should be done. So it is the need of the hour. So there are two ongoing randomized control trials. One is the RACC or REC trial and ROC trial, ROCC or GOG 3043 trial. So in the RACC trial, the primary objective is to investigate the oncological safety of the robotic-assisted laparoscopic surgery as compared to the standard laparotomy. Total 768 patients will be recruited. So inclusion criteria is the histologically confirmed primary adenocarcinoma, squamous cell carcinoma, adenosquamous carcinoma of the uterine cervix, and figure stage 1B1 and B2 excluding the 1B3, and stage 2-1 and 2A1 will be included. And the surgery will be type B or type C radical hysterectomy as per the Quadrimodo classification. Performance status 0 to 1, patient must be suitable for surgery, and informed consent will be taken age more than 18 years. Now the histopathology as the exclusion other than that is squamous, adenosquamous, and adenocarcinoma, tumor size greater than 4 centimeter, FIGO stage 2 to 4 except the 2A1, and the patient had a history of pelvic or abdominal radiotherapy, pregnant patient contraindicated to surgery, pelvic periodic node more than 2 centimeter, patient not willing or not able to stand withstand the surgery will be excluded. The primary outcome is the recurrence-free survival, and the secondary outcome is the overall survival and health-related quality of life, intraoperative complication, post-operative complication, to look for the diagnostic accuracy of the pelvic sentinel lymph node, then healthcare cost. So duration of the study is 8 years, inclusion is for 5 years, and follow-up for 3 years. So the trial started April from May 2029 and estimated to be closed in the May 2027. So similarly, another trial, that is a ROC trial, In the ROC trial, it is a multi-centric prospective randomized non-inferiority trial. The primary objective is to determine whether the robotic assisted radical hysterectomy is not inferior to the open, that is abdominal surgery with respect to the 3 year of disease-free survival. And the secondary objectives are overall survival, pattern of recurrence, peri and postoperative complication, then the impact on the patient-reported outcome, and the lower, that is the lower extremity lymphedema. The inclusion criteria is the adenosquamous adenocarcinoma, FIGO 2018, stage 1A to 1B. MRI confirming that is the cervical tumor less than 4 centimeter, no obvious evidence of extra cervical extension, no nodal or other regional metastasis, no use of no uterine manipulator will be used, and the detailed surgical technique for proper tumor containment is required, and photographical evidence will be kept. 840 patients will be enrolled, 420 per arm, and which provides 90% power to exclude any absolute decrease in the disease-free survival 7% with the long range, that is a log range test to look for the non-inferiority with one-sided alpha of 0.05. So result of this trial may be practice changing and will either support or refute the findings of the LACC trial. Now the conclusion, we all know when there is a change, there is a protest. So when the calculator came out, the math teachers start protest in 1966. The same thing happened with the computer. When it came out, people started protest. So the change is uncomfortable, but it is necessary. So in conclusion, we can say while the debate regarding the cost, comparative value, standardized training, safety, and oncological outcomes are ongoing, robotic assisted surgery will likely continue to remodel the surgical management of gynecological conditions. Robot has potential for telemonitoring and telesurgery, unlike conventional laparoscopy. As the technology continually improves, it will undoubtedly continue to be preferred surgical approach for a significant number of subspecialists in the treatment of gynecological malignancies. To pursue of quality evidence regarding the gynecological oncological outcomes, quality of life, cost effectiveness, and the education in robotic assisted surgery should be determined the best practice ongoing forward. So as we know, see in different science fiction movies, so the surgeon itself is replaced by the robot. We don't know what future holds for us. So with this, I'm going to conclude here. Thank you so much.
Thank you, Dr. Bijay, for a nice and comprehensive presentation. Yes, robot is inevitable, and robot should come to India in a greater way. Till now, there are few centers which are having the robotic surgery. Many of them are doing the robotic surgery for non-gynecological cases, non-oncological cases. But some of the centers who are doing the robotic surgery are doing mainly for uterine cancer, endometrial cancer. But after having the LAC trial, people are avoiding the laparoscopic or robotic surgery, minimal access surgery, because there are a lot of issues which have come, which has been highlighted greatly by Dr. Bijay. I'm really thankful for a comprehensive presentation. Here, Dr. Archana is here. Do you have any comment to make regarding the robotic surgery? You have an experience in performing the robotic surgery in your institute. Can you tell us regarding doing your experience in robotic surgery? Dr. Archana, are you there? I think link is missed. So, Dr. Kostov, you are regularly doing the robotic surgery in oncological cases. In which of the oncological cases you are including robotic surgery, and how far you are getting the success out of it?
Right. So I start with the last slide of Dr. Bijoy, whether the robot will replace human. So definitely not. So our existence will still be there.
Okay, so that's a great thing. That's a good I mean, message
so
is there.
Basically, why the robotic surgery is much of a practice in gynae oncology specifically. We have seen all the centers where the robot has been, the inception of robot has started is mostly the centers which practice oncology. If you see the history of robotic surgery in India as well as across the world. So the reason is we do some special procedures which require skill, right? So it is skill driven, because we have to do radical surgeries, we have to go into the retroperitoneum, we have to dissect the pelvic nodes, we have to preserve the nerves. So these are very skilled procedures. And laparoscopy, we have tried laparoscopy in these cases and we have done it successfully, but it has limitation, as Dr. Bijoy has already
Yes, because the greater level
showed us very nicely that it has. So if you move the laparoscopic instruments down outside the abdomen, inside the abdomen, what happens is, am I audible?
Yes, you're audible.
Yes. Inside the abdomen, what happens is it moves on the other way around. So it is called counterintuitive motion. And to overcome this counterintuitive movement, you have to have a steep learning curve. It does not occur in one day. So it takes at least 5 years to attain that level. So on contrary, in robotic surgery, because of the endorist movement, okay, so basically what robot is doing is it is just replicating our joints. If you see the robot structure, it has number of joints. So like we have shoulder joint, elbow joint, wrist joint. So practically it is just replicating the joint movements. So and the human is only moving the master controller sitting on the console. So the with little bit of movement in the master controllers, there is so much movement in the robot. So we call this the movement is exponentially replicated, right? So that's the advantage. And because especially with all the reports, what we have seen, all the evidence, we have not seen any difference in oncological outcome. So oncological outcome is always the similar as expected. But the LAC trial has its own demerits. We all know that.
Yes, it has got a lot of limitations.
A lot of limitation. If you see the number, only 15% were the in the robotic arm. So maybe with the results coming in RAC and ROC trial, and even the MIRRORS trial, not I would say ovarian cancer surgery in a interval debulking setting is still not a standard of care. But eventually, with learning curve, with the people who have started interval debulking surgery, like the likes of Dr. Somsekhar, they are already at least 3,000 plus robotic surgeries. So with that, the huge experience, you can you can try doing interval debulking in case of ovarian cancer. But as of now, as you said, Dr. Mondal, we are still limiting ourselves to endometrial cancers. And even in endometrial cancers, we have operated few endometrial cancer which are locally advanced, stage 2, stage 3. In those cases also robot comes very handy, because in that we don't have LAC trial limiting us. So we have done many robotic cases in advanced endometrial cancer. We have done exenterations, and we have seen advantages of dissection because of the endorist movement, because of the 3D vision. We have appreciated that it is you can go to as deep as the pelvic floor, and the biggest advantage is there is no loss of focus. You can move very fast.
Yes.
And the focus is not lost. But unlike in laparoscopy, when you go close to the organ, you have to change the focus and refocus it.
Yes, yes.
And the camera is completely under your control. That's the biggest advantage. You are all in laparoscopy, you are completely dependent on somebody who is always showing you, and there is a dependency. If you miss that person, people tend to cancel their cases. But in robotic, you are in a complete command of the situation.
In fact, those who are practicing for the first time minimal access surgery, robot would be a preferred one instead of going for laparoscopy, because
absolutely
is a long learning curve, and instead robot has a low learning curve. Now the thing is, the cost wise, the robot is it is not justified replacement of laparoscope because of the low and middle income countries. They cannot afford robot in almost all centers. In fact, if you look at the situation, laparoscope is available almost all centers in India. Even the smaller nursing homes, you will find the laparoscope, but you will not find the robot in almost in every cases. But robot has a definite advantage over laparoscope that is already well established. Now, Dr. Archana is here. Dr. Archana, are you there?
Yes, sir.
Yes. Can you give your special comment regarding the robotic surgery?
I fully agree with Dr. Kaustav Basu, and I would just like to add one thing. It is not only the surgeon; it should be the whole team which need to be experienced. And there is one point: whenever we started robotic surgery, there was one time of the total time taken in the surgery. So initially, whenever somebody starts, somebody is a robot and starts their practice in their center, the team is also inexperienced, so it takes a lot of time in documenting and everything. But as you become experienced, it hardly takes 10 minutes, and your surgeon, your anesthesia people also become experienced. So the total time taken is not at all longer than laparoscopy. That this is one point I would like to make. It is only the training of the whole team and how it works like a well-oiled machine. If your team, then it will not take time. And if you see the whole presentation, the number of conversion in laparoscopy were much higher than robotic surgery. It is the failure, loss of pneumoperitoneum. This person who is showing the camera is not stable. The surgeon gets frustrated, fatigued, and ultimately it leads to conversion whenever you face any difficulty. So the number of conversion of robotic surgery is much lesser. So it is just the adaptability, the cost wise, of course, I do agree the cost. But if you see the total stay of the patient in the hospital, if you are working in government, then it's all right. But if in private, when every day cost, so ultimately the stay of the patient in the hospital will be much lesser. And I hope
in that way, in the Western world, it is most cost effective because staying in the hospital is charged more rather than the cost of the instruments and their consumables. So I think robot is a little bit cheaper in the Western world, but as the initial cost is high, so and the no cheaper attachment facilities are available in India. So that's why robot is not promoted in many centers. But I hope robot will come, robot will take care, and robot will replace laparoscope in near future if things are affordable to all of us. Now, there is one question: what disadvantages of robot if apart from cost and availability? What disadvantages of robot can you tell, Dr. Kaustav?
What, as ma'am said, Archana ma'am said that initially the time, initial part of your learning curve, because all the technicians are also learning, so the entire team is learning, anesthetists are learning. So initial part of the learning curve, the time used to take long. But with cases, 50 cases, 100 cases, you grow with your team. And as she said, just 10 to 15 minutes, the entire docking process. So that is one disadvantage, I would say, that the time management. Second is, if you say the tactile feedback. So that's the biggest disadvantage. But believe me, after 40, 50 cases with your learning curve, you hardly need that tactile feedback. It's like a reflex you develop. With learning curve, that is also abolished. And even this intuitive, they are bringing up a new generation robo, or they are just updating one software that can give tactile feedback at in your fingertips. So these new things are happening. With all this, technological advancement, I think all the negativities will be gone in future.